Hi, good afternoon. This is Dr. K with Dominion Fertility. Thank you so much for joining us. This is What's New Wednesday, and today's topic is going to be endometriosis and infertility. So we'll discuss endometriosis associated infertility. Many women are affected by endometriosis. It's very common, and generally we predict about 176 million women around the world has this condition. It's chronic condition, and it is very troubling for the patient and also for the physician to manage. It can present in a wide variety of symptoms. Some women have endometriosis and have no symptoms. Sometimes this is diagnosed during a surgery. Some women have pelvic pain and some ovarian masses, or some women have endometriosis associated infertility. Now, the risk factors for endometriosis is smoking, alcohol use, and there are certain ones that that are dictated by our genetics. Early menarche in women who had menarche, who had their first period before age 11, they're at a higher risk to develop endometriosis, and also those who have short cycles, less than 27-day intervals, are more likely to have endometriosis. Now let's come to endometriosis and infertility. Sorry. Among infertile women, up to 50% there's a chance that they're going to have endometriosis. And among women who have endometriosis, 50% of them have infertility. So among patients that I see, there's a good chance that we will have some complication or some endometriosis-related infertility problems. Now, we don't exactly know if endometriosis causes infertility, but there's an association. The reason being, if it really were to cause infertility, we would be able to treat it. And there are multiple medical treatment options for endometriosis, and once it's treated, fertility outcomes would be higher, but that is not the case. But there are different mechanisms that are proposed that may cause or that might lead to infertility. One of which is makes a lot of sense, because endometriosis leads to pelvic anatomy distortion, because endometriosis is an inflammatory process, and these women, with or without surgery, end up having a lot of adhesions in their pelvic area, and that distorts the anatomy, meaning tubes could be adhered to bowels, and they don't function as they would normally do. And actually, we know this because if the pelvic anatomy is restored to its normal state, those women have increased fertility outcomes. Of course, this is through surgery. Now, the other mechanism is through egg quality. We also believe endometriosis can cause impaired egg quality, because it changes hormonal or endocrine system in the body. In those women who have endometriosis, they tend to have premature LH surges, meaning their ovulation is not normal, and post-ovulation progesterone levels are not normal either. So this impacts the fertility outcomes as well. Another mechanism that we well know is the inflammatory process is all through the pelvis, and those inflammation are actually through inflammatory cytokines in the pelvis, and that can affect ovulation and actually transport of the egg from the ovary to the uterus itself through the tube. And even then, if the tubes are not affected, in endometriosis patients, there are several studies that show the egg transport is impaired regardless of the tube being functional. So what happens is about up to 60% of the time, egg is not transported to the uterus that it would normally do in a patient without endometriosis. Now, also uterus, of course, this is endometrial tissue elsewhere found in the body other than the uterine cavity. So the uterus is also a little functioning differently in endometriosis patients, in the sense that there are implantation problems. So when we make embryos from patients with endometriosis through IVF, and then when we transfer them to the patient, we see impaired implantation rates. And of course, there are many studies that suggest even the embryo quality could be impaired in endometriosis patients. So these are all different aspects of endometriosis when it comes to infertility that affects and might not necessarily cause infertility, but this is why and how they're associated. Now, diagnosis of infertility, actually, let's start with that. As for those patients with endometriosis and who have not been using contraception and who have decided to expand their family and want to have a child, if you've been trying for over 12 months and did not achieve a pregnancy, that is the definition of infertility. So at that point, then we diagnose our patients with endometriosis-associated infertility. Now, the diagnosis of endometriosis, usually by the time an endometriosis patients come and see us infertility specialists, they already have a diagnosis, but they may not. But diagnosing endometriosis, it's surgical, but the surgery is not necessary all the time for purposes of treatment. It is surgical because we have to take endometrial tissue from the pelvis and then actually send it to histology, and that way we can prove the patient has endometriosis. But when patients come in with pelvic pain or pain with intercourse and painful periods, and because of painful periods, they start missing work, those are actually very good signs and symptoms that patient actually has endometriosis. And then if they're their treatment or management can be started without surgery if needed. Now, when it comes to managing a patient who has endometriosis and who is trying to get pregnant, it's a little tricky because management of endometriosis, effective management of endometriosis, is through suppressing the ovaries. Basically, we want to suppress the estrogen levels so that the endometrial tissue does not grow anymore. However, that also means contraception, because when we try to suppress the ovaries, we also prevent the ovaries from ovulation, and inevitably patients at that point are not fertile anymore. Effective treatments could be birth control pills or Lupron shots, but those are not going to be consistent with achieving pregnancies. So when patients stop their treatment, their symptoms probably resume, which is mostly pelvic pain. Among patients with pelvic pain, endometriosis is about actually 80% prevalent. Now, what happens is they try for about 12 months, and if they can't achieve pregnancies, then they come and see for infertility specialist. Now, at that point, we have certain decisions to make for these patients. Since medical management is not an option, what do we have? Does surgery help? Well, first of all, suppressing ovaries and then letting patients achieve pregnancy has not been found to be very effective. And offering them surgical options is also very controversial because especially in mild endometriosis cases, surgical approach does not lead to higher live births in infertility patients. Okay, so then we have two tools we can offer our patients. And those are the superovulation or ovulation induction with insemination, and the other one is IVF. And I will discuss those options briefly, but are there any questions so far? No. Moving on to the IVF and the superovulation part, I'd like to discuss the impact of endometriosis on the ovary. And I think this was a question posed by one of the patients on Facebook. And the answer to that question is, does endometriosis affect the ovaries? And the answer is yes, it does affect the ovary. It does affect the ovarian health. And it does affect even the embryo quality. And there are many studies that actually have shown that. Now, offering patients with endometriosis, there are a couple of studies that show using Clomid, which is an oral agent that may help increase the number of eggs that you're going to ovulate during that cycle, combined with insemination, benefit mild endometriosis patients. And that is definitely better than expected management. when we discuss expected management, after 12 months, the likelihood of patients achieving pregnancies on their own with no medical help in endometriosis patients is actually less than about 4%. And that is definitely a lot less than what the normal rate of pregnancy should be month to month in patients who don't have endometriosis, and that rate is about actually 20%. So using agents like Clomid or injectables with insemination does increase live birth rates in patients with endometriosis, and mostly mild endometriosis. Now, the other issue to discuss would be IVF and endometriosis. Do patients with endometriosis, can they benefit from IVF? And the answer is actually yes, because through IVF, studies show that endometriosis patients achieve higher live birth rates. But then the question is, there are many decisions that needs to be made between the patient and the physician, depending on the patient's situation. Not every endometriosis patient is the same. As we discussed before, symptoms can vary from nothing to pelvic adhesions to severe pelvic pain, and the same goes for infertility. When they present with infertility, the reasons could be different. Someone with endometriosis, which we consider severe stage 4 with large endometriomas on ovaries, is going to respond differently to IVF than a patient who has mild endometriosis. So in that regard, the patient and the physician has to discuss the options and how to actually prepare themselves for IVF. Several studies try to explain or actually show any benefit of surgery before starting IVF. And that's a controversial area because some patients or some studies show that after surgery, their IVF or their patients benefited from IVF versus other studies show differently. What we know is we should not offer routinely surgery before IVF to all endometriosis patients. The ones who would benefit from it are the ones who actually have symptoms. For instance, if a patient has large endometriomas, and specific size actually in the study is shown to be about 4 centimeter diameter, and this is a significantly large size endometrioma, and and they're symptomatic, meaning they have pelvic pain, which probably most likely they will. In that case, resecting that endometrioma and then continuing with IVF might benefit the patient. But otherwise, there are not many cases where the surgery will benefit the patient before IVF. And then the other question we get is, if the patient has symptoms and they have endometriomas and they're thinking about going through surgery, the question raises, is the surgery going to affect their ovarian reserve? Because with or without the surgery, endometriosis patients have low ovarian reserve, meaning their AMH levels compared to their age match controls are lower. And after surgery, there are several studies who show the ovarian reserve or after resection of an endometrioma, their ovarian reserve is going to be further decreased. And does this pose a challenge to their IVF treatment? Well, when the studies looked at this problem, actually they show that resection of endometriomas, although it does decrease ovarian reserve, the live birth rates are equivalent, so they're similar. So those patients should be counseled accordingly and should not avoid symptom relieving surgery before their IVF. At the same time, those endometriomas will be a risk factor during the egg retrieval process because of the size and obstruction of the ovaries and so forth. I think there's a question.
There sure is. So Mary asked, she said she was diagnosed with stage 4 endometriosis with 1 tube blocked. They put her on Depo, the Depo injection. How long do they have to be off of the Depo before they can begin a treatment, before they can begin an IVF cycle?
Well, I think the easiest answer would be once they resume their cycles would be the best time, and usually in a month or 2 they should be able to resume their menstrual cycles.
After they're off the shot?
Yeah. Okay. After they're off the
okay.
shot. And actually, there's no waiting time. Some people resume their cycles immediately and start ovulating immediately.
Great.
And, so there shouldn't be any delay. Well, are there any other questions?
No, I think you've done a great job explaining it. Thank you.
Of course. Thank you so much for joining us for What's New Wednesday. And thanks for your questions, and thanks for being with us.